My name is Ryan Massa. I'm a second-year oncology fellow here at UPMC Hillman Cancer Center. Did my training here earlier as well, discussing new immunotherapy treatment options today. So the framing of the topic, new immunotherapy treatment options, is interesting because a lot of the drugs we're using as standard of care, these checkpoint inhibitors we've been talking about all day, are actually still fairly new. So I thought I'd take a step back and use this as an opportunity to discuss the history of cancer immunotherapy, going back over 100 years, and really focus on the mechanism of immune checkpoint blockade. And then we'll discuss the currently approved but still new treatment options that we use, as well as the immunotherapy that's in development under clinical trial investigation. So in 2015, a few years ago, the American Society of Clinical Oncology, our professional organization, announced cancer immunotherapy was the advance of the year, which is very exciting. And then in 2016, immunotherapy 2.0 was the advance of the year. And then in 2017, again, adoptive cell immunotherapy was the advance of the year. That's most recent. So Dr. Devar talked about this as well. 10 years ago, cancer immunology was not a hot field. Since I've joined fellowship training here, it's all anyone wants to do. It's really what we talk about on a daily basis. Most of our new fellows we recruit to the program are interested in immunology to some extent. So this field, despite being now a hot field, goes back fairly far back in medical history. So in the late 19th century, William Cooley was a surgeon in New York who became interested in case reports of patients with a type of tumor called sarcoma who were observed to have some shrinkage in their tumors following a bacterial blood infection. And he hypothesized that this decrease in tumor size might actually be due to the bacteria infection causing the immune system to become revved up and attacking the tumor. This is the front page of his publication investigating this idea from 1893. And he investigated this by injecting a bacteria called streptococcus, or strep infection, into patients and published his results in 1893. So we've moved on since then. So this was 19th century. 100 years later, BCG, which is a kind of bacteria, was developed for the use in bladder cancer. So in certain kinds of localized bladder cancer, BCG is instilled directly into the bladder, and it stimulates an immune response. So similar to that initial concept that Dr. Cooley identified 100 years previously. And this is still used today, BCG for localized bladder cancer. In the early 90s, high-dose interleukin 2, or IL-2, was approved by the FDA for renal cell cancer, and then in 1998 for melanoma. IL-2 at high doses promotes the activity of a certain kind of immune cell called CD8 positive T cells, among other immune cells. And while this regimen can be particularly toxic, for some patients they can have a good, durable response. Interferon alpha-2b is a treatment that promotes the activity in a kind of T cell called T helper cells. And this is approved in the mid-90s for patients with melanoma that was completely removed by surgery, so the adjuvant setting, to reduce the risk of recurrence. And then finally, checkpoint inhibition, which is what most of us are familiar with today. I marked 2011 here on our timeline because this is the year the FDA approved the first checkpoint inhibitor, ipilimumab, for unresectable melanoma. And I'll spend the next few minutes discussing checkpoint inhibition, as it's probably the most common type of immunotherapy we use in patients with solid tumors today, including melanoma. So you've seen more complex versions of this diagram here today, but I felt this was a good opportunity to discuss how checkpoint inhibition works on a straightforward level. So on the left, you have a tumor cell. On the right, we have a T cell. There's multiple kinds of T cells. We'll just describe it as an immune T cell right now. So cells, in general, as Dr. Delgoff said, have many different molecules on their surface that allow them to interact with their environment. These are two of them. These interactions can have many different effects, including making the cell more active or making the cell less active. And this interaction here between the immune cell on the right and the tumor cell on the left leads to activation of the T cell, and this activated T cell kills the cancer cell. This is a process that goes on every day, and as your immune system identifies malignant cells and kills them. As I said, there are many, many molecules expressed on the surfaces of cells, and here's a sampling of some known interactions between immune T cells and tumor cells. We'll focus on the most widely used immune therapy in practice, which is PD-1 and CTLA-4. PD-1 being Opdivo and pembrolizumab, and CTLA-4 being Yervoy. So again, we have the tumor cell and the T cell, and the interaction at the bottom there is what we want to see happen, lead to tumor cell killing. But I've drawn in blue the PD-1, PD-L1 interaction. That's what nivolumab and pembrolizumab affect. So when this interaction forms, we have the T cell that's unable to kill the tumor cell. It leads to decreased immune surveillance. So this T cell is no longer doing its job of killing the tumor cell. So through the use of a type of drug called a monoclonal antibody, which pembrolizumab and nivolumab are, we can block this interaction. By blocking this interaction, the T cell becomes reactivated and then kills the tumor cell, which is our goal. So this is the goal of this intervention, to activate the sleepy T cell and reinitiate T cell surveillance and tumor killing. So Melissa talked about this a little bit too, so I won't spend too much time here, but this activated T cell is now killing the tumor cell, which is good. But this activated T cell is also going to potentially, in some patients, attack other normal tissues. So we can see this with the toxicities that we see with the checkpoint blockade, like when it attacks the bowels and can cause colitis with diarrhea and abdominal pain. It can attack the liver and cause autoimmune hepatitis, which is a lot like any sort of autoimmune hepatitis someone can get not on checkpoint blockade. It can cause rashes, pneumonitis, and then hypothyroidism and pituitary problems. Melissa went into more detail about the toxicity, so I won't spend too much time here. But the toxicity we see with checkpoint blockade are certainly not hair loss, infection that patients experience of the traditional chemotherapy, but it's more autoimmune toxicity. So treatment, sometimes depending on the patient's situation, we'll stop the drug, we'll sometimes give steroids, and less commonly, but occasionally if severe, we'll give medications, like infliximab or Remicade. Moving on to the immunotherapy we're using now in clinic, and I'm going to focus on the new immunotherapy, meaning the ones in the last 5 to 6 years that we've been approved. And what's interesting is these drugs are new enough that we're still developing new uses for them. So ipilimumab, an anti-CTLA-4 agent, initially approved in the unresectable or metastatic setting, and also approved for stage 3 disease that's been completely surgically removed. You're probably all familiar with these two. Anti-PD-1 drugs like Keytruda or pembrolizumab, which is used in the unresectable or metastatic setting. And then Opdivo or nivolumab, which was also used and is still used in the metastatic setting, but as of November, December, was approved for stage 3 melanoma that's been completely surgically removed. So that's stage 3 melanoma that's been removed by a surgeon, and the nivolumab is then given to reduce the risk of recurrence. So that's a new use for still a new drug. One of the ways these drugs are being studied now is in combination, both with the agents we already know how they work and with newer agents as well, which I'll get into shortly. So this is an approved combination of 2 new immune therapy drugs. Nivolumab and ipilimumab are used in combination in patients with metastatic or unresectable melanoma. And the combination has, in the study that was done, showed an increased response rate at the cost of some increased toxicity. So a lot of our physicians who see melanoma in the clinic, who are experienced with these drugs, will have different ways of interpreting this data, whether some patients will be given both these drugs up front, some will have a drug added on later, and it depends on the patient's situation. In combination, in summary, there's probably increased benefit, but some increased toxicity as well. And the question exists, which isn't fully answered yet, is what the ideal sequence is in these drugs, whether it's better to start with one and add one on later, vice versa, start with both up front. These are questions that are still being answered. So I didn't want to finish up without talking about other immune therapies in addition to checkpoint inhibition, because these are important as well. In general, these are used somewhat less often in present day in 2018, but they may still have a role in the treatment plans for some patients. TVEC, the first one, I won't read out the whole name out. TVEC is a modified oncolytic, so cancer-killing herpes virus, designed to produce an immune stimulatory protein. So this is an FDA-approved therapy, and it's the first FDA-approved oncolytic virus therapy. It's injected directly into the tumor. It's used in patients for local treatment of unresectable lesions who occur after initial surgery. Interferons are naturally occurring proteins that are administered in the treatment setting at high doses. And interferon is given after surgery to reduce risk of recurrence, and that was approved in the mid-90s in the adjuvant setting for melanoma after it's been surgically removed. Lastly, interleukin-2. Interleukin-2 is a type of molecule called a cytokine that stimulates the immune system. And again, when given to patients with melanoma in the treatment setting, we give it at very high doses. This is a treatment that we hospitalize patients for because the toxicities from it can be fairly severe. They're usually hospitalized for several days while they receive the IL-2 treatment. It can be fairly toxic, but some patients can have a prolonged, durable response. So future directions. So earlier in this talk, I showed a slide of the many molecules expressed on the cell surface, which have a role in modulating the function of the immune system. And many of these molecules are under development, under investigation as potential drug targets. So I'll go through some of them now. These are inhibitory molecules like the PD-1, PD-L1 axis we discussed earlier and what nivolumab and pembrolizumab both attack. TIM-3, the first one here, when TIM-3 binds to its corresponding protein, it leads to death of the immune cell. So blockade of TIM-3 with antibody treatment is being studied in combination with anti-PD-1 antibodies. LAG-3 is another one of these molecules on the cell surface. It's present on immune cells, and when it binds to its corresponding protein, it leads to decreased immune activity. So there's early data from a study of anti-LAG-3 and anti-PD-1, nivolumab, in patients with melanoma, all of whom had already received standard of care anti-PD-1 therapy. And that was presented at one of the National Society meetings last year, and the early data was encouraging, but this is still under investigation. The last one here is IDO, and IDO is actually not a molecule on the surface, it's an enzyme inside the cells that inhibits the function of the immune T cells. An inhibition of IDO to increase T cell function is under investigation. These molecules are stimulatory molecules, so we want to increase the effects of these molecules in the therapeutic setting. 4-1BB is a stimulatory molecule, and there's an antibody with some promising early data in combination with nivolumab in this drug, again, still under investigation. CD40 is a surface molecule that helps activate T cells, so it's being studied in combination with both anti-CTLA-4 antibodies and anti-PD-1 antibodies. GITR is also being evaluated in patients with melanoma currently. And the last one here, KIR. KIR stands for killer cell immunoglobulin-like receptors. And it's it's a molecule that's under investigation with an inhibitor of KIR, and that's being studied in combination with ipilimumab and nivolumab. Lastly, I want to focus on one more topic here. I mentioned that ASCO announced adoptive cell immunotherapy was the advance of the year for 2017. So here we have a trial in multiple solid tumor types with adoptive T cell therapy. So you'll see tumor-infiltrating lymphocytes, or TILs. I'll use the word TIL from here forward to describe those. So TILs are immune cells that have migrated into a tumor. They've infiltrated into the tumor. So TIL therapy is a multi-step process, and it involves first removing the tumor, cutting the tumor out. Then TILs are extracted, prepared, manipulated, and expanded in a laboratory setting. So not necessarily in a test tube, but in a test tube-like setting. But separately, the patient from which the tumor was removed and the TILs were extracted is admitted to the hospital and given chemotherapy to suppress their immune system temporarily. While that's happening, these TILs that have been expanded in the laboratory from the patient's own body are then given back to the patient at a high dose with the goal of destroying any remaining tumor. In the protocol we use here, we actually give IL-2, which we use in other settings, to stimulate the immune system as well at the time of TIL infusion. So this is using the patient's own immune cells, expanded in a laboratory setting, and then given back as a kind of treatment for melanoma. This technology is under study in melanoma among other different tumor types. So, brief overview of the history, the current state of the field, and future directions. It's an exciting time. Thanks very much for inviting me to speak today, and I'll take questions.